Good morning, folks. It's John Adamson, the Rehab and Documentation Guru, hoping you're staying COVID-19 free. The other thing is, I hope you're not panicking. Part of the problem with our country is that we've gone into massive panic mode, not helped by the 24-hour news cycle on COVID-19, no doubt. But I wanted to talk about something different today. I have a case scenario for you. So we're going to look at a man who's advanced in age. So I'm just going to say in general, he's over the age of 85. He's living in the home. He's got the signs and symptoms of early stage dementia. And so he's forgetting things. He's repeating himself. He's not completing activities fully. And he's demonstrating impulsiveness. And that's going to be germane to what I'm going to talk about. The reason that I received the referral on this guy is because he was falling a lot. And he's been progressively falling more and more over the last 3 months. So with that said, here's some of the things that I was noticing about him. Number one, for his age, this guy was in pretty darn good shape. I mean, you don't reach advanced age in general unless you've had a fairly healthy life. And this guy had a fairly healthy life. He had a fairly minimal amount of medications for his age. He had some comorbidities. One is that he has atrial fibrillation when he's under anesthesia. So otherwise, he's not been known to have that. More on that maybe in a little bit. He has generally normal blood pressure, like around the 120/80. And he's living in his home with a spouse and loved ones. Very good social situation for this guy. Excellent support. Generally a positive attitude, but he's starting to get to that stage of dementia where he's getting easily frustrated. And so we got the referral for him because of a declining function. And some of his frustration is manifesting in an unwillingness to participate in some ADLs. So whenever I see a patient who's having a risk for falls, like many of you, I'm going to look at all causative factors. And so I did a systematic review of what was going on with him. Let's start off with vital signs. So his vitals were 120/69 at rest, blood pressure. Now, that's a great blood pressure for a younger person. But in general, as age advances, we see that blood pressures tend to climb. Now, is that necessarily optimal? Well, probably not. But it is indicative of some concerns or some things that are going on physiologically in the older person. One thing is we lose elastin as we get older. So that elastic recoil of our tissues goes down. I mean, you can see, like, I've got this going on in my neck now. You know, my tissue doesn't bounce back like it used to when I was younger, where I had this, nice, smooth neckline. And sometimes it'll look like I have a double chin, even though I'm not fat. It happens. We lose that elasticity. And that happens in your arteries as well. And so if an artery becomes more stiff, just because of the natural process of aging, we would expect blood pressures to rise a little bit. So this guy's already starting at a blood pressure that's a little bit on the low side, given his age. Now, one of the things that I looked at was other responses cardiovascularly, and one was his heart rate. He started off at a heart rate of in the low 70s. We walked for a little while, and he got a little bit short of breath for a longer distance walk. Not bad for a 90-something-year-old guy, and he was cruising along. And when we got done with the walk, I noticed his heart rate had not responded. So that tells me something may be going on cardiovascularly. He has no diagnosis of cardiovascular disease. The other thing I looked at for him was his pulse oximetry. And he was resting at 95%, which is excellent for somebody with advanced age. But he did drop down to 92%. Now, some people will say, okay, that's fine. Not going to worry about that, but that's not normal. It's not normal when you work harder for your O2 sats to drop. If anything, they probably should go up because you're breathing more deeply. The other thing is, and many of you have heard me say this before, I always look at my patient's feet. This guy had remarkably good feet for his age. The skin color was the same as more proximal tissue. That's a good sign. The feet were warm. For the most part, his nail beds looked okay. But on both large toes, both big toes, he had thickening of his nail. He also had clubbing of the toenails, especially the first and second toe had clubbing. Now, clubbing can be a clinical sign of hypoxia. So I'm going to assume this guy has some PAD. And then I'm going to assume that he's got some other issues going along with that. So we'll kind of come back to that. The next thing I'm looking at is balance on this guy. He scored a 20 out of 28 on the Tenetti. He's not walking with a device, so he scored that without a device. That's not bad for a guy with advanced stage, but it's still a deficiency. One of the things I noted about him was he had a very wide base of support generally when he was standing, sometimes a little bit more than his shoulder width, and that was comfortable for him. And when he walked, he definitely walked kind of legs akimbo, legs out, wide base of support. And he could diminish that base of support, but then he get a little bit loss of balance then. His vision is very good, especially considering his age, and his eye tracking, from what I could tell, seemed to be pretty good. His inner ear, vestibular, seemed to be pretty good. Again, very remarkable for a guy of his age. But then when I put it all together, and I looked at also his balance reactions, which were pretty good for his age, possibly better than mine. I was impressed by the fact of how good he was doing, but I was also impressed by the fact that it appears he has some peripheral sensory issues going on. And why do I say that? Not only do I see this vascular insufficiency potentially of his feet, which may be causing some peripheral nerve die-off, but I'm also seeing what's called sensory gait. So while he's walking, he's kind of doing this clodding, boom, boom, boom type walking. And sensory gait is a mechanism that patients use automatically to improve the sensory awareness of their foot when it hits the surface that they're walking on, to help them establish better balance control. So I'm assuming this guy has some peripheral neuropathy issues, even though he's not diagnosed with it. So another issue that I'm looking at. Impulsivity. The guy has early stage dementia. He's making bad decisions about his walking. I took him on a path around his house. There was an opportunity he had to go around an obstacle or by it, and the path going by it was very thin. That's the one he chose. Didn't need to, had ample opportunity to go around it. So he's making bad decisions, which is going to influence him. Now, I want to come back to cardiovascular because there's something else I forgot to point out. So he's got this slightly atypically low normal blood pressure for his age. And I talked to the family who was there and the patient, and I said, I suspect that when you arise, because they told me that some of his falls were prior to the fall, he had been bending over to reach for something. I said, I suspect that you've got some postural hypotension, that when you go to stand up, your blood pressure may be dropping, and it's dropping too low for your body to handle. And they said, oh yeah, that reminds me of this, 4 weeks ago, he stood up from the couch and he got real dizzy, and he said his vision clouded, and I said, that may be a concern. So we need to probably figure out a way to increase his blood pressure with activity. And so I just mentioned talking to the doctor about possibly, compression stockings. There's medicine that it can increase your blood pressure, but, medicines can cause other problems. And so I said, maybe you need more salt in your diet to bring your pressure up just a little bit. And I'm talking about all salts. So I said, these are things you want to talk to your doctor about. And these are the things that I reported to his physician for follow-up, because I think there's a lot more going on with this patient. And even though he's advanced age, he's enjoyed a fairly high level of functionality, and I think he needs to continue to enjoy that so his family can take care of him in the home. Oh, one other thing. This guy has a beautiful house facing a lake. The lake actually is on the southern aspect of his house, and he's got this humongous bank of windows that faces the water, and the afternoon sun just pours into the house. Guess where some of his falls have happened? In there. And I talked to them about the tremendous amount of glare that they were probably getting, not only light coming directly from the south, but bouncing off the water into the house. And so he has these sharp contrasts of light in his home that are probably causing problems. So anyway, these are things that we covered. If you, based on what I've told you, have any suggestions about ideas that might also be going on, feel free to comment. Please like and subscribe. If you like these case scenarios, if you find them to be helpful, please let me know, because I like doing them. I think, part of my channel is on documentation, obviously. Part of it is on clinical. And if you document strongly clinically, you're proving medical necessity of care. And that's why I bring this stuff up. Anyway, again, hope you're staying healthy and happy. Take care, and God bless.